Welcome back to the Nurse's Study Partner. This is Meningitis, Part 1, Recognition, Diagnosis, and Emergency Care in 10 in-depth scenarios. We'll define meningitis, recognize the classic triad, the meningococcal rash, and the Kernig's and Brudzinski signs, spot the subtle signs in infants, use lumbar puncture and CSF to diagnose and tell bacterial from viral, give emergency antibiotics, and prevent spread with precautions, prophylaxis, and vaccines. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A student nurse is asked to explain in simple terms exactly what is inflamed in meningitis and why it can be so dangerous so quickly. Which statement best defines meningitis? Option A. Inflammation of the lungs' air sacs from infection. Option B. Inflammation of the heart's inner valves and lining. Option C. Inflammation of the meninges around brain and cord. Option D. Inflammation of the liver caused by a viral infection. Pause here and choose your answer. The answer is C. Inflammation of the meninges around the brain and spinal cord. Meningitis is inflammation of the meninges, the protective membranes, the dura, arachnoid, and pia that surround the brain and spinal cord, usually from infection. Because these membranes sit right around the central nervous system, infection can cause rapid neurological damage, raised pressure, and death. So bacterial meningitis is a medical emergency. It is not a lung, heart valve, or liver condition. Question 2. A 19-year-old university student is brought in very unwell with a high fever, a severe headache, a stiff, painful neck, and growing drowsiness and confusion. He also dislikes bright light. Which classic combination do these findings represent? Option A. Fever, neck stiffness, and altered mental status, the triad. Option B. Chest pain, breathlessness, and ankle swelling only. Option C. Joint pain, a butterfly facial rash, and hair thinning. Option D. Burning on passing urine with lower back ache alone. Pause here and choose your answer. The answer is A. Fever, neck stiffness, and altered mental status, the classic triad. This triad, often with severe headache and photophobia, is the classic picture of meningitis. Importantly, fewer than half of patients show the full triad, so meningitis must be suspected whenever some of these features appear together in an unwell patient. The other options describe unrelated conditions. Question 3. A feverish, very unwell teenager develops a rash of small red purple spots that spreads quickly. When the nurse presses a clear glass against the spots, they do not fade. What does this indicate, and what is the priority? Option A. A harmless heat rash. Simply cool the skin and wait. Option B. A mild allergy. Give an antihistamine and reassure. Option C. A blanching viral rash. No urgent action is needed. Option D. Meningococcal septicemia. Emergency antibiotics now. Pause here and choose your answer. The answer is D. Meningococcal septicemia, and the priority is emergency antibiotics now. A non-blanching petechial or purpuric rash, one that does not fade under a pressed glass, in a feverish, unwell patient signals meningococcal septicemia, bleeding into the skin from Neisseria meningitidis. This is a life-threatening emergency needing immediate IV or IM antibiotics and urgent transfer. It can progress to shock and death within hours. It is not a heat rash, allergy, or harmless viral rash. Question 4. A patient with suspected meningitis is examined. When the hip is flexed and the nurse tries to straighten the knee, there is pain and resistance. And when the neck is flexed forward, the hips and knees flex involuntarily. Which two classic signs are being described? Option A, Homan's sign and Murphy's sign of the abdomen. Option B, Kernig's sign and Brudzinski's sign of meningism. Option C, McBurney's point and Rovzin's sign of appendicitis. Option D, Trousseau's and Chvostek's signs of low calcium. Pause here and choose your answer. The answer is B, Kernig sign and Brudzinski sign of meningism. These are the two classic signs of meningeal irritation. Kernig sign. With the hip flexed, extending the knee causes pain and resistance. Brudzinski sign. Flexing the neck causes involuntary flexion of the hips and knees. Both suggest meningitis but can be absent, so normal signs do not exclude it. The other options belong to other conditions. Question 5. A 5-month-old baby is brought in irritable and feeding poorly with a high-pitched cry and fever. The anterior fontanelle is tense and bulging, and classic neck stiffness is hard to detect. How should a nurse interpret this? Option A, normal teething. Give teething gel and reassure. Option B, simple colic. Advise winding and a warm bath. Option C, possible meningitis. Urgent assessment needed. Option D, ordinary hunger. The baby just needs more feeds. Pause here and choose your answer. The answer is C, possible meningitis needing urgent assessment. In infants, meningitis signs are subtle and non-specific. Irritability, poor feeding, a high-pitched cry, fever or a low temperature, drowsiness or floppiness, and a tense, bulging fontanelle, which signals raised pressure. The classic neck stiffness is often absent. This baby needs urgent assessment and treatment. It is not teething, colic, or hunger. Question 6. A patient with suspected meningitis needs a definitive test to confirm the diagnosis and identify the organism, and the team asks when imaging is needed first. Which is the key diagnostic investigation? Option A, lumbar puncture for CSF, with CT first if there are raised ICP signs. Option B, a routine chest x-ray is enough to confirm the diagnosis. Option C, a urine dipstick alone reliably diagnoses meningitis. Option D, an abdominal ultrasound scan to look at the meninges. Pause here and choose your answer. The answer is A, lumbar puncture for CSF, with a CT first if there are raised ICP signs. The key test is a lumbar puncture to obtain cerebrospinal fluid for cell counts, protein, glucose, gram stain, and culture, plus blood cultures. A CT head is done first if there are signs of raised intracranial pressure, reduced consciousness, focal deficits, papilledema, or seizures to avoid brain herniation or coning. A chest x-ray, urine dipstick, or abdominal ultrasound cannot diagnose meningitis. Question 7. Two patients have lumbar punctures. Patient 1's CSF is cloudy with very high neutrophils, high protein, and low glucose. Patient 2's CSF is clear with lymphocytes, mildly raised protein, and normal glucose. Which interpretation is correct? Option A. Both samples are completely normal and reassuring. Option B. Patient 1 is viral. Patient 2 is clearly bacterial. Option C. Both point to exactly the same type of meningitis. Option D. Patient 1 is bacterial. Patient 2 is viral meningitis. Pause here and choose your answer. The answer is D. Patient 1 is bacterial and patient 2 is viral. Bacterial meningitis CSF is typically cloudy with high neutrophils, high protein, and low glucose because bacteria consume glucose and it is under high pressure. Viral or aseptic meningitis CSF is usually clear with lymphocytes, normal or mildly raised protein, and normal glucose. So patient 1 fits bacterial and patient 2 fits viral, not normal, not reversed, and not identical. Question 8. A patient arrives acutely unwell with a high fever, neck stiffness, a spreading non-blanching rash, and drowsiness. Bacterial meningitis with septicemia is strongly suspected. Which action is the priority? Option A. Wait several hours for all results before any treatment. Option B. Give empirical 4 antibiotics immediately without delay. Option C. Send him home to rest and return if he feels worse. Option D. Start only oral vitamins and simple paracetamol. Pause here and choose your answer. The answer is B. Give empirical IV antibiotics immediately without delay. Suspected bacterial meningitis or meningococcal septicemia is a medical emergency. Empirical IV antibiotics such as ceftriaxone or cefotaxime plus ampicillin if listeria is a risk must be given immediately alongside resuscitation. Do not delay antibiotics waiting for the lumbar puncture or results, and dexamethasone is often added. Waiting, discharge, or vitamins and paracetamol alone could be fatal. Question 9. A patient is admitted with confirmed meningococcal meningitis. The nurse must protect other patients, staff, and the household contacts who share the patient's home. Which infection control actions are appropriate? Option A. No precautions are ever needed for any meningitis. Option B. Strict lifelong barrier nursing in a sealed room. Option C. Droplet precautions, antibiotic prophylaxis for contacts. Option D. Contact tracing is unnecessary and never carried out. Pause here and choose your answer. The answer is C. Droplet precautions plus antibiotic prophylaxis for close contacts. Meningococcal disease spreads by respiratory droplets, so patients need droplet precautions until about 24 hours of effective antibiotics. Close and household contacts are offered antibiotic chemoprophylaxis, such as rifampicin, ciprofloxacin, or ceftriaxone, to clear carriage and prevent secondary cases, and cases are notified to public health. No precautions, lifelong sealed isolation, or refusing contact tracing would all be wrong. Question 10. A community health nurse in an area within the African meningitis belt is planning how to reduce cases of bacterial meningitis, especially in children. Which is the most effective preventive strategy? Option A. Vaccination, meningococcal, pneumococcal, and Hib programs. Option B. Encouraging crowded indoor gatherings in dry season. Option C. Discouraging any childhood vaccination in the region. Option D. Relying only on treatment after people fall seriously ill. Pause here and choose your answer. The answer is A. Vaccination programs, meningococcal, pneumococcal, and Hib. The most effective prevention is vaccination. Meningococcal vaccines, crucial in the African meningitis belt, where serogroups A, C, and W cause dry season epidemics, plus pneumococcal and Hib vaccines. These have dramatically reduced bacterial meningitis. Outbreak response, chemoprophylaxis for contacts, and health education also help. Crowding, discouraging vaccines, or relying only on late treatment would increase cases and deaths. Let's recap meningitis part 1. Meningitis is inflammation of the meninges around the brain and spinal cord. The classic triad is fever, neck stiffness, and altered mental status. A non-blanching rash signals meningococcal septicemia, an emergency. Kernig's and Brudzinski signs show meningeal irritation. In infants, look for a bulging fontanelle, poor feeding, and irritability, as neck stiffness is often absent. Diagnosis is by lumbar puncture with a CT first if there are raised pressure signs. Bacterial CSF is cloudy with low glucose. Viral CSF is clear with normal glucose. Bacterial meningitis is an emergency needing immediate IV antibiotics. Use droplet precautions and give prophylaxis to close contacts, and prevent it with meningococcal, pneumococcal, and Hib vaccines. Keep going, and remember, we don't pass alone, we pass together.